Good evening, sir, and everyone. I take this opportunity to welcome you all on behalf of Hetero Healthcare. I am Neeraj Prashar, the sales manager for Helion, our CNS division of Hetero Healthcare. First of all, thanking you all for joining us today, to discuss on this important topic of Cariprazine, a novel antipsychotic treatment option, particularly in schizophrenia. To brief you about Hetero, like we all know, we have one of the largest R&D wings, which, is providing 360-degree solution to pharmaceutical industry. Hetero, has a more than 25 years of excellence in multiple therapies with presence in over 126 plus countries worldwide, including the regulated markets around the globe. Hetero also has more than 200 products across various therapeutic categories, and one of the leaders with HIV, AIDS, oncology, cardiology, vascular, neurology, and so on. Particularly, very importantly, also, Hetero Healthcare has a distinction of bringing 4 biosimilar products to the global market. That is possible with the help of 36 plus state-of-the-art manufacturing facilities, which are pioneering in quality as well as in innovation. With this little brief about Hetero Healthcare, I would now take this esteemed opportunity to introduce our esteemed Dr. Parmod Kumar, who is there with us. And just to introduce, Dr. Parmod had done his MD Psychiatry from PGIMR Chandigarh in the year of 1996. Prior to that, he has done his MBBS from Medical College Rohtak in the year 1991. In his past, Dr. Parmod has been our Honorable General Secretary of IAPP, also has been the Distinguished Editor and Vice President of Indian Association of Biological Psychiatry. At present, Dr. Parmod Kumar is running since 2014 a comprehensive psychiatric and neuromodulation clinic in Chandigarh and Tri-City by the name of Dr. Parmod Clinic, equipped with the world's finest technology for treating resistant depression as well as OCD. Prior to that, Dr. Parmod has been a senior resident at PGIMR Chandigarh in 1996 up till 1999, after which he had been a psychiatrist working as a consultant psychiatrist at Silver Oaks Hospital, Mohali from 2000 to 2014. Giving that brief about Dr. Parmod Kumar, I would now request Sir to kindly take over this forum and take us through, the topic and share your experiences to discuss more on the subject. So with this, sir, I would request you to kindly take over and educate us about your clinical experiences for Cariprazine in schizophrenia.
Okay, thank you, Neeraj. And every few months there is an opportunity to talk about something which comes new in psychiatry. So this is a molecule. I'm going to talk about Cariprazine, and I always use any molecule which comes into the market. I go into the science behind that, then go into the research behind that, and then try to use it, and then to decide whether I should continue to write or discard, whatever is my experience in my own way, in my own clinical wisdom. I do some kind of a research in my clinic as well. So let us see whether Cariprazine has given me that kind of a confidence till date, whether I should be using it or not to be using it. So in this presentation, I'll try to establish with a lot of research evidences whether Cariprazine has any role in psychiatry. Okay, if that is so, what is being backed up by, and what is as far as this molecule is concerned, what is the pharmacodynamics of this molecule? How does it work in schizophrenia? What is its efficacy in bipolar disorder, adverse event? And I'm going to summarize towards the end what is it all about. Now, if you look at the Cariprazine, it is developed by G. Rister, and it is an approved medication in US by US FDA in schizophrenia, bipolar 1 manic, and mixed episode, and bipolar depression. In Europe and UK, it is approved only and only for schizophrenia. And in India, it is approved for schizophrenia, bipolar 1 manic, and mixed episode, not for depression as far as India is concerned, which is there in USA. Now, this is something like we, as an introduction. So whenever we talk about any drug, this is very important to see what are the antipsychotics, just a kind of a to make it better understanding. So we know there are first generation antipsychotic, there are second generation antipsychotic, and there are third generation antipsychotic. First generation, main and second generation, their primary action was on D2 receptor, and they were all mainly into the antagonist category. So this is what you can see, D2, and then it came into 5-HT2 as well. And then came this current medication which we see, and let me see, D3. So with the third generation antipsychotic like aripiprazole, brexpiprazole, and cariprazine, the effect came onto D3 receptor. That was the primary target along with the D2. That doesn't mean D2 has disappeared, and it has a partial agonist properties. Okay. Just a second. Okay. So whatever antipsychotics are there in the market till date in psychiatry, so there must be some limitations. That is the reason the newer and newer molecules have come into. So I have been using this for almost 3 decades now. You can say more than 3 decades by this time. And with second generation, when the second generation antipsychotic came, so we were extremely thrilled. I said during my junior residency, oh, now we have to get away from haloperidol, and then risperidone and other molecules came over a period of time. But even with the second generation, overall response is not that satisfactory. And at least 40% of the patient do not respond at all. Further, first generation and second generation have a limited efficacy on negative symptoms and on cognitive symptoms, which is another very, very important domain of a schizophrenia. And this the persistence of a negative symptoms that lead to poor prognosis, longer lasting disease, greater functional impairment, and less response to drug treatment. And so they have done meta-analysis, and they have seen that not that they do not work at all in negative symptoms. There's some of the second generation do work in negative symptoms like amisulpiride, clozapine, olanzapine, risperidone, but not to that great extent. Definitely not. And they also induce significant side effects. First generation and second generation both induces significant side effects that lead to patients' poor compliance or treatment discontinuation. Another, which we see every psychiatrist, that's always a concern about patients, that the continuation of treatment and the treatment side effects. Although second generation reduce the risk of some of the important side effects like extrapyramidal and hyperprolactinemia, but they provoke relevant adverse effects, especially weight gain and metabolic syndrome. Hyperprolactinemia is also seen with many of the second generation antipsychotics. So that bring the need for a newer antipsychotic with low risk of sedation, extrapyramidal, prolactin elevation, metabolic syndrome, and more so, especially during the maintenance therapy. Because in acute therapy, you see there are many side effects which patients or the family members are able to accept during the acute phase. But this is a long-term treatment, okay? But in the long term, it is not at all acceptable. So treatment for negative symptoms and cognitive impairment, treatment for bipolar depression. So these are the other dimensions of the efficacy. So does cariprazine check all these boxes or most of the boxes? Let me take you to the research. So cariprazine, what is it? It's a DAPA. DAPA is a dopamine antagonist and partial agonist with dopamine D3 and D2, preferably D3, and serotonergic 5-HT1A receptor partial agonist properties. So it has an antagonist property, it has a partial agonist property. Mainly, it is a partial agonist on D3 and D2 receptors. And that is a chemical name for this molecule. The exact mechanism of cariprazine in schizophrenia is also not very well known, because that's there with most of the antipsychotic. But I believe, in my understanding, I do not exactly say we do not know exactly. We know a lot about it. Maybe in the kind of disorders which we deal with, it is not possible to pinpoint, because we do not have a one cause disorder. However, the efficacy of cariprazine could be mediated through a combination of partial agonist activity at D3 primarily and 5-HT1A receptor, and antagonist activity at serotonin 5-HT2A receptor. So, agonist and antagonist properties at these neuroreceptors is primarily responsible for the effects of cariprazine, and it has two metabolites which are called dis-methylcariprazine and di-desmethylcariprazine, and they have a properties which are similar to the parent drug. So this is a receptor binding. So it has a partial agonist at D3 and D2 receptor. Partial agonist at D3 and D2 receptors. Affinity for D3, D2 is more, which I have already told you. Partial agonist at 5-HT1A receptor. Antagonist at 5-HT2A, 5-HT2B receptor. Bind to H1 receptor. Low affinity for 5-HT2C, alpha 1 receptor. Negligible binding for muscarinic and cholinergic receptors. So why this is very important to understand at what receptor this medicine works. The next slide I'm going to tell you. This is exactly the mechanism of action of cariprazine and what do we expect out of that. So D3 partial agonist, the primary function of cariprazine, it leads to improvement of positive symptoms, negative symptoms and depressive symptoms, cognitive symptoms, and little adverse effect like EPS and hyperprolactinemia. So D3 receptor partial agonist itself is able to explain all the functions what we expect out of a cariprazine. Not only that, it has a D2 partial agonist properties also, which also does almost the similar effect and absence of the negative effects. 5-HT1A partial agonist, it primarily is responsible for negative and depressive symptoms improvement. And rest of the antagonistic properties at 5-HT2A, 2B, 2C, and 7, they are primarily responsible for reduction of the extrapyramidal side effect and improvement in the depressive and cognitive symptoms. So we must be focused on the first D3 and D2 receptor, which is the most important mechanism. So what does this D3 receptor through this side, if you see, D3 receptor antagonism and partial agonism could hypothetically improve cognitive symptoms and cognitive impairment. Because when it exerts this kind of an action, it leads to increase in dopamine in the prefrontal cortex. And this increase in prefrontal cortex, which improve negative symptoms, cognitive symptoms, and mood symptoms. So the more and more dopamine is available in the prefrontal cortex, and that is where the improvement in the negative and cognitive symptoms takes place. As far as the metabolism is concerned, pharmacokinetics are concerned, peak time to plasma concentrate is 3 to 6 hours following oral administration. Metabolism primarily by CYP3A4 and to lower extent by CYP2D6 from D-CAR to DD-CAR. Elimination is 20%, 21% is expected in urine, and 1.2% goes unchanged in the urine. Half-life is long. It has a long half-life for 2 to 4 days and approximately 1 to 3 weeks if we look at the metabolite of that. And it's the plasma concentration of DD-CAR decreased by about 50% after 1 week. Rather, this when I started using it, this is exactly the mechanism. I use single dose, and I started to believe that this is a molecule which can be used in a alternate day, third day, fourth day, maybe at a 7 days interval over a period of time. This search need to focus in this particular area as well because of side effect. Now let us see the doses and administration in schizophrenia. The recommended doses is 1.5 milligram to 6 milligram once daily. The starting dose for in every psychiatric disorder is 1.5 milligram. Then it can be increased on day 2 or to 3 milligram. This is a recommendation. But again, every psychiatrist have their own wisdom to titrate the patient according to their tolerability. And the maximum permissible dose is 6 milligram per day. In manic and mixed episode, it is the same kind of a pattern which is to be followed. 1.5 to begin with, then go from 3 to 6 milligram, and titration is quick. In depressive symptoms associated with bipolar 1 disorder, the starting dose is 1.5 milligram per day, and depending on the clinical response, dose is hiked up to after 2 weeks. Recommendation is to hike up to after 2 weeks to 3 milligram, and not more than 3 milligram is being recommended, because that is where the maximum patients respond. Now, this is about the molecule till now. Okay, pharmacokinetic, pharmacodynamic, and the doses and the indications which we have discussed. Let us see whether research support it, whether there is say, okay, this is a molecule. I'm going to talk about research in different disorders. First is in schizophrenia. So there are 3 randomized control trials in acute schizophrenia, all placebo-controlled, 2 risperidone and aripiprazole, and the dose which was used is 1.5 to 9 milligram per day, 2 fixed dosage and flexible, and 1 randomized control trial versus risperidone for negative symptoms, and 1 RCT versus placebo for prevalence, for relapse prevention. This is the first most important study I can tell you, and this is the whole of the recommendation, the approval, everything has come after this study, which was way back in 2014-15 published. So this was a 6-week randomized double-blind placebo-controlled study evaluating the efficacy and safety of cariprazine in adult patients 18 to 60 years with acute exacerbation of schizophrenia. So acute schizophrenia, they have done 6-week randomized double-blind trial, and on the you can see this. I'm not going to go into details of each and every study because that's going to take a lot of time. But there are 3 studies, study 1, study 2, study 3. So PANSS total score improvement at week 6 was statistically significant versus placebo. So this is how any molecule get approval, placebo-controlled studies. So if they do better than placebo, that means it has some meaning in psychiatry or mental health or any research. And they have seen the cariprazine was better than placebo on CGI-S. Benefit is dose dependent, 1.5 to 6 milligram, and benefit is apparent from week one. And in study 1 and 2, PANSS total score improvement was similar to risperidone and aripiprazole. So they were similar. So then what is the difference? Difference is with regard to the side effect profile, which I have already told you. So acute, many drugs did improve the acute psychosis, but did that maintain the recovery over a period of time? So this is a long-term study of 92 weeks. That included 20-week open label phase and 72-week double-blind placebo-controlled. So the adult patient who met DSM-4 criteria of schizophrenia, 765, not a small number, who were clinically stable, following 20 weeks of open label cariprazine at 3 to 9 milligram, were randomized to receive either placebo or cariprazine at the same dose for up to 72 weeks in double-blind study. And that whole aim was to see the relapse prevention, how the relapse happened. So the patient of cariprazine showed significantly longer time to relapse versus placebo at 72 weeks. And then the 25th percentile, 50th percentile that was seen, and between group separation of the curve did not occur until around day 50. In the initial 50 days, the response was almost similar. So there were 2 simple takeaways from 72-week double-blind study. 48% of the patients remaining on cariprazine had 48% lower risk of relapse as compared to the placebo. 48% lower risk of relapse, and after 1 year, when they were followed after 1 year, 35% of the cariprazine patient relapsed versus 56% of the placebo. So it has a role in the long-term treatment as well. So first is acute treatment, second is a long-term treatment. Then let us see whether it works in the particular dimension of schizophrenia or it works in across all the dimensions of schizophrenia. So in the same study, they have seen that there was a statistically significant difference between the placebo and the cariprazine. It showed in all the 5 PENS factors, and on the 26 out of 30 PENS items, you can see negative symptoms, positive symptoms, disorganized thoughts, uncontrolled hostility, anxiety, and depression. So all the dimensions came down with cariprazine. Now, this is hostility is another very, very important parameter of schizophrenia acute psychosis. So I'm just going to highlight most important finding. So changes from baseline to week 6 was statistically significant of all PENS hostility item analysis in favor of cariprazine versus placebo, and they were adjusted for their another benzodiazepine or any other drug which was also used simultaneously. Now comes to the monotherapy for treatment of predominantly negative symptoms in patients with schizophrenia. So this, like I was telling you, in negative symptoms, this is between cariprazine and risperidone. They have given 26-week monotherapy with RCT in 66 centers. It's a European country, across Europe, 11 countries, adult with more than 2 weeks of schizophrenia and predominantly negative symptoms. So negative schizophrenia they have seen. Oral cariprazine 3, 4.5 or 6 milligram were risperidone was used 3, 4, and 6 milligram per day. Now look at the response. So if you see the blue line is cariprazine. So all the negative symptoms of schizophrenia came down significantly when they were being put on cariprazine versus risperidone. And the functional improvement also happened simultaneously. So that is here the social performance was assessed in the second scale. Then it has seen proven anti-manic efficacy for bipolar 1 manic or mixed episode. So they have given 3-week randomized double-blind placebo-controlled studies evaluating the efficacy and safety of cariprazine in adult patients with manic or mixed episode of bipolar 1 disorder with or without psychotic features. In each study, primary endpoint was LS change from baseline to YMRS. So significant change in YMRS score in bipolar manic or mixed episode studies. So there was they have studied on a YMRS and they have found that all the parameters on YMRS, they came down, a significant change in CGI. The dose was 3 to 12 milligram and no maintenance therapy because it was acute treatment. Again, they have seen on all the 11 parameters of components of YMRS score items on SIMI. So it has shown this, the dark boxes, they came down and the gray boxes were on the upper. So this is a placebo and dark columns are the cariprazine. So all the 11 parameters it had shown improvement. So it is not only in schizophrenia, it's in depression, it is in negative symptoms, it is in manic symptoms as well. And this is about bipolar 1 depression. Again, this is another 6-week and 1 8-week randomized double-blind placebo-controlled studies evaluating the efficacy and safety of cariprazine in adult patients who met DSM 4TR and DSM criteria for depressive episode during. So it's a bipolar depression during the depressive phase. So they have studied on a MADRS score, and the dose was 0.75, 1.5, and 3 milligram. So at 0.75, no change from placebo. 3 milligram changed only in one study. 1.5 milligram changed in all the studies. So 1.5 milligram per day was the most consistent dose, which has been seen to be effective in bipolar depression. Again, the same like in mania they have done. So on MADRS, they have seen that all the parameters of MADRS scores, it has seen from apparent sadness to anhedonia, then inner tension, then reduced sleep, all the parameters with cariprazine improved. So I have tried to find out the best of the studies which can support the use. That doesn't mean I'm promoting cariprazine in any way, but these are the research evidences and they were the most quoted studies for cariprazine. As far as the adverse events are concerned, because adverse event, I told you in the beginning, is the most important parameter to go for in any newer medication. So cariprazine is not free of a side effect. Let me tell you, it's not something which we can say, oh, he doesn't have any side effect. So they have seen placebo, risperidone, aripiprazole. With that, they have compared. So dropout rate because of the adverse event was 12% versus 3.11% versus 9%, 9%. So dropout rates are not that different as compared to the other antipsychotics are concerned. EPS, 8% in placebo. Placebo, they have given 8% of EPS, 15 to 20% with cariprazine versus 27% with risperidone. And aripiprazole has always been on the lower side. As far as the somnolence is concerned, maximum with risperidone, the rest all are on the lower side. Akathisia, very important side effect, very common side effect with cariprazine. It is equivalent to risperidone. And weight gain is, you can say 0.8 to 2 kg with cariprazine. It is again comparable to risperidone that way, but my clinical experience is not way that as the research says. In schizophrenia study, prolactin reduced with placebo, cariprazine, but increased with risperidone. We all know that. And prolactin reduction with cariprazine was greater in negligible change in heart rate, blood pressure, ECG, lipid, and smaller increase in blood sugar parameters like a small metabolic side effect. As far as the adverse effects are concerned, where incidence is more than 5% and at least twice the rate of placebo. So depending on the disorder like schizophrenia, bipolar mania, bipolar depression, extrapyramidal symptoms across all, akathisia across all, and in bipolar mania, dyspepsia, vomiting, somnolence, restlessness. The same is in bipolar depression also. I don't know why in schizophrenia this was not reported, or maybe the incidence was less. QTC, no change with QTC has been seen. Drug interaction, as I have already told you, reduce cariprazine dose by half if any strong inhibitor of CYP3A4, and if it is an inducer, then concomitant use is not recommended. One case report I have found about overdose of 48 milligram. Patient experienced orthostasis, hypotension, sedation, recover full on the same day, although the half-life is long, and management was done by the simple principles like any overdose. In elderly, the studies are lacking. Too few elderly patients included in phase 3 clinical trial. Lower doses recommended for poor hepatic immune function, given risk of drug interaction. So you have to weigh your own risk as when you are dealing with with dementia patients because it leads to adverse events. Implication for use in liver disease, mild liver disease, I would say then no dose adjustment. But if it is a moderate to severe liver disease where CP score is 10 to 15, then you can avoid this molecule. Same is the clearance in renal disease also. If the renal clearance is less than more than 30 ml per minute, no dose adjustment, but if it is less, it's not recommended. So let's come on to the salient features. So what have I tried? Let me try to summarize. So cariprazine is a new orally active dopamine D2, D3 receptor partial agonist, so which has been tested, researched for treatment of schizophrenia, bipolar disorder, and depression. The relative long plasma half-life and the persistence of 2-active metabolite support single daily dosing. So very comfortably you can give single dose at any point of time. So dose in the dose of 0.5 to 12.5 was well tolerated. Treatment emergent adverse events, I've already told you. No clinically significant meaningful change in metabolic parameter, prolactin elevation, QT, prolongation in cariprazine. Broad spectrum psychotropic drug because it is effective against negative symptoms, effective against hostility in schizophrenia. It helps in relapse prevention schizophrenia, effective against manic and mixed episode, and effective in bipolar depression. Low risk of EPS, sedation, and weight gain, no prolactin elevation. So these are some of the favorable side effects which I think are there. So you can now, this is all about my presentation on cariprazine. I close my session. Now I'm open to any discussion, question, comments, clarifications.
Right, sir. Thank you. Nilesh, can we share the queries with sir?
Definitely, sir. So, sir, there are so many questions has been came. So I'll
Yeah.
just take the questions and I'll paste in the chat box.
Okay.
Nilesh, we can start now.
Just a second.
Okay, sir.
Chat. Let me open it. What is the
Yes, sir.
maximum? Yes, I can read it. So, what is the maximum dose of cariprazine in any symptoms? 6 milligram per day is the which the most of the researchers have indicated. 6 milligram.
All right.
How we differentiate in terms of side effect profile aripiprazole versus cariprazine? I have just given you the slides on the side effects of cariprazine versus aripiprazole. That's why I have compared all these. Aripiprazole on the extrapyramidal side effect, you see on the lower side, sedation is lower side, weight gain, metabolic syndrome. Everything is on the lower side of the aripiprazole. Cariprazine is somewhere in between risperidone, olanzapine, amisulpiride, and somewhere in the middle of this. Okay, although it has EPS, it has akathisia, it has nausea, it has weight gain, and it has got the hyperprolactinemia also as well, but limited. Can it be given in positive symptoms along with first generation? Yes, it can very easily be given. Follow the same principle of diet titration, whether you want to add on or whether you want to substitute. In MDD, which antidepressant is suitable with cariprazine? So I have not come across any particular studies on it. You say a particular antidepressant versus the.
Sir, it could be about your clinical experience. Like,
yes, I have. Okay. In my clinical practice, along with cariprazine, the most suitable drug which I use is SSRIs, so broad spectrum antidepressant, and it works wonderful. Can it replace aripiprazole? Yes, definitely it can. I have been trying to shift my patients on from aripiprazole to cariprazine. The reason is aripiprazole work wonderful in the maintenance phase. I have seen in my so many years of experience. As far as the acute psychosis is concerned, I'm not at all confident about aripiprazole. So in acute patients, even in the maintenance phase, if somebody is still struggling with the non-recovery, partial response, I shift them to cariprazine.
No, I think, sir, this is a very important point you mentioned. The maintenance side of it, cariprazine would be a better option.
Yes.
Right, sir.
And maybe over a period of time, you see a medication coming up once in 3 days, once in a week, or something like that, which will improve the compliance in any way. How cariprazine in acute exacerbation of schizophrenia alone? I have used although the research says that you can use monotherapy in acute exacerbation of schizophrenia, the first study, which says, but I have used in the acute phase of schizophrenia, and I'm quite confident it can work. Sir, please.
Sir, alone or as add-on, sir? I missed on it. Sir.
No. Individual monotherapy.
And a monotherapy, sir.
Yes,
right. Right. Now, sir, the other question is very commonly, which a lot of people, a lot of psychiatrists have been asking.
How you avoid akathisia? See, the simple principle goes that start with 1.5 milligram. Like I was mentioning that akathisia is the earlier side effect of cariprazine with any antipsychotic. It comes very quickly in the beginning. So I do not recommend it to be increasing so fast. So I have the follow my patients after a week time. Okay, the science says go after second day or third day. So you observe the akathisia, which is very, very troublesome. So I use propranolol and lorazepam to manage akathisia, and it worked wonderful.
Okay, that's very important, sir. Yeah, that's important, good, sir.
Any sexual side effect you have seen with cariprazine? Till date, no. Till date, I have not encountered. I do ask sexual side effect in each and every patient.
And sir, do papers suggest, sir, any sexual side effects with the use of cariprazine?
No. To the best of my review which I have done, I've not found any sexual side effect particle particularly. This is a new molecule. It will take time for it to establish.
Right, sir.
And organic psychosis, cariprazine is suitable. I would say that there are two things that I have. One is a long half-life of this drug, and the minimum dose is 1.5. It is available in capsule form. Okay, so like we follow the standard principles of the minimum doses, like haloperidol 0.25, 0.5, risperidone 0.25, 0.5. So it becomes difficult to titrate this molecule, especially in a geriatric population with many comorbidities. So there I have a question mark whether I should be using it or I shouldn't be using it.
Okay.
The same goes with dementia-related psychosis. So I'm not at all comfortable, although I have seen the research evidence that it is being tried in the people with but not a great favorable outcome has been seen.
Correct.
IPD and OPD, cariprazine is used more than IPD. Is it a question or is it a comment?
It's a query, sir. It's a query.
It's a query. It's a very much an OPD-based practice. It's a OPD-based medication. You don't have to admit anybody for that.
Right, sir. Right. Nilesh?
Yes, sir. As of now, we have this many questions only.
Right. Okay. So I think, sir, these were the queries as of now. And I'm sure, sir, in times to come, post this session, we'll be having further more queries. So which I'll definitely be taking, sir, your insights, to address them. So
Okay.
I think, sir, with this, then, we can conclude the webinar. And, sir, your insights have been very informative and your content and experience are well received, for sure with the audience. And I think, sir, it would significantly contribute towards the use of cariprazine as an option, treatment option for treating patients with schizophrenia. I and Sir Hetero are very grateful to you for your willingness to take time out and share your knowledge and expertise on the subject with us and with the audience. Particularly, sir, I would like to mention that your presentation was very enlightening. And we are confident that the audience also would be benefited, greatly from your insights and clinical expertise. Sir, I would thank you again for your time today for this academic webinar. And, going forward also, sir, we would be looking for, many more such, academic webinars where we would like you to share your esteemed clinical experiences about, not only cariprazine, but all the other drugs also. So with all my, sir, due regards, sir, I'm thankful for to you for taking this time out and educating us on the subject today. Thank you so much and hope to see you, sir, soon again on this another platform of webinar with Hetero Healthcare, sir. Thank you, sir.
Thank you.
Thank you
very much.
Thanks, sir. Thanks.
Okay, bye.
Thank you, sir.